Hi everyone, welcome back to our journal club, and sorry if you saw the other video for the technical difficulties. I'm just adding our guest speaker tonight, who is Paul O'Leary, and I just sent him an invitation. Great, and we should be on in just a moment. He is also I don't know if you guys recall last week, our last speaker was from Alabama, and so is Paul. Hi there. Hey, Paul.
Hey,
Hi. Yeah. Sorry, I don't
can you
know
hear
what
me
happened with
okay?
that last video. But welcome. Welcome, everybody, and welcome, Paul. Let me just pull up his, pull up his, his bio. And thanks for joining us. So Dr. Paul O'Leary completed his adult residency and child and adolescent fellowship at the University of Alabama in Birmingham. He went on to complete his forensic fellowship at Emory University. Dr. O'Leary contracts with hospitals and government agencies to provide psychiatric coverage for inpatient units and for juveniles in detention. He's not a researcher, but he is involved in a number of professional organizations, including the APA, the AMA, Apple, and ACAP. He currently serves on the board of the APA and is the speaker-elect in the APA Assembly. As speaker, he is working closely with Bruce Swartz, APA's president-elect, to educate, clarify, and advocate for the appropriate roles of mid-level providers in psychiatry. The reason he went into psychiatry was to provide care that not only improved with physical health, but also mental health and overall quality of life. He's glad to be a psychiatrist because of the wide varieties of opportunities the field has afforded him. He joined Psychiatry Network when it discussed offering educational videos about the ABPN articles, and we thank him for helping out with this endeavor. He is a big advocate for organizing our profession and think this is an excellent way to achieve that goal. So thank you for that, and yeah, welcome. Why don't you start out and tell us what article you're covering tonight and get into it? Sure.
Sure. Thank you very much for having me. I really appreciate this opportunity to discuss a forensic article of one of the curated 40 articles from the ABPN. The article we'll be discussing tonight is Collaboration to Reduce Tragedy and Improve Outcomes, law enforcement, psychiatry,
Right.
and people living with mental illness. The article is a review article, and basically, to put it in a nutshell, it's how do patients and communities benefit from crisis intervention teams? And even though the title doesn't say crisis intervention team in it,
Mm-hmm.
that's ultimately what we're talking about. Crisis intervention teams are something that's been around for 20, 30 years, but over the last 5 to 10 years have really started taking off. And there's a number of crisis interventions in most all of the states, and that's what we'll be talking about today, because one of this, how do psychiatrists get involved with their law enforcement? What are some of the ways to do that? Because it does have good outcomes. As far as the authors go, there are 3 authors. Dr. Niels Rosenbaum is the first author, and the one who is primarily writing this and has no financial interest with pharma companies. Then there's Detective Matthews, who he worked with, no financial interest. And then Mauricio Tone is the chair of the psychiatry department in Albuquerque, and he's supported by 25 different pharma companies. So if you ever wanted to see alphabetized all the different pharma companies you could work for, just look for his financial disclosure. So it starts out, this article, with a beige box that basically goes through a story to tell you how an individual can benefit from the crisis intervention. It talks about a homeless man who would stand in the corner and basically have the delusions that he was speaking to someone who needed him to remain clean, and so sometimes he would just preach on the corner. Sometimes he would start losing weight because the person he believed he was talking to told him that he needed to be pure. Sometimes he'd throw rocks. And the police and the hospitals had a tough time dealing with him because the police would take him in, but the hospitals wouldn't find him having necessarily meeting the criteria for admission, and so put him back out. And so around and around he went. Then they got in the crisis intervention team involved, and they had actually started building a rapport over time. And after they built rapport, he started losing weight again, and they were actually able to get him into treatment at that time. He agreed, he was admitted, and he's now no longer on the street, but been receiving services and doing well for the past 3 years. So then it goes into the background of the problem, and it basically says that, as we all know, there's not enough psychiatrists. And what's happening is, because you've got hospital beds closing, because there has been cuts in terms of how much time psychiatrists get to spend with patients, and because of the increased number of patients who are having psychiatric disorders or psychiatric illness, you're finding an increased interaction of law enforcement with psychiatric patients. And in fact, the article goes on to suggest that law enforcement had more interaction with psychiatric individuals than any psychiatrist would. So a partnership between law enforcement and psychiatry therefore could lessen the burden of hospitalization, lessen the burden of potential poor outcomes with interaction with people with mental illness, and also potentially lessen the liability factors that the police departments are suffering due to their interactions with individuals. So there's also been a lack of data that kind of really has been continuing to fuel this misunderstanding between law enforcement and psychiatrists, and part of this has been hampering their effective partnership. One of the things that hampers that is we really don't know how many of the calls are really due to psychiatric illness versus something else, because law enforcement doesn't code for psychiatric illness. They'll code for a domestic dispute, but they're not going to code for domestic dispute because he was schizophrenic or because she has borderline personality disorder. And so it's unclear how many of these interactions are actually dealing with psychiatric issues. However, they have tried to do some estimates, and what's interesting is the best data shows that between 3 and 10% of law enforcement interactions involve people with mental illness. The only outlier of that, and I do recommend downloading the supplemental material because it actually talks about it in that supplemental packet. The only outlier is when the police department of Albuquerque did a self-rating scale, right, where it was asked of the officers, hey, how many of the cases that you get called out to involve someone with mental illness? And so they said 1/3. So even though the number is probably closer to 3% to 10%, clearly these are very memorable cases and tend to bias or at least skew the police to thinking that 1/3 of the people they interact with have mental illness. So clearly, just from this data alone, even if we don't consider the third, you still have a number of people, because in Albuquerque, right, where you've got 800 sworn employees, there are 500,000 or approximately 500,000 calls. And so if you just take the most conservative number of 3%, right, that's still 15,000 calls or 15,000 people who the police are interacting with who have mental illness. So they're actually serving or interacting with more people than the local hospitals, than the psychiatrists, really than any other of the health professions. And so this is why partnering them would seem like a really good thing to do, because clearly they're having interaction with a significant number of people who are in mental distress or have mental illness issues. So what is the role of the psychiatrist in law enforcement? And that's the next part of the article. It basically goes on to talk about how psychiatrists Don't necessarily have to be the front line, though you certainly can. A friend of mine, while I was serving on the Psychiatry and Law Enforcement Liaison Committee, actually was working in a CIT team and would go out with the SWAT team. He'd wear the flat jacket, he had a badge, all that sort of jazz, and he would go out and he would do hostage negotiations, or at least talk people down who were suffering with mental illness. And so we're not saying that everyone needs to go out and get your badge and learn how to talk people down, but a psychiatrist can be very helpful just by facilitating access to other providers and administrators. Many jurisdictions have a unique set of laws that regulate what a psychiatrist can do or physician can do, which is more than a social worker can do, which is more than a nurse practitioner can do. In fact, a psychiatrist has to be present in order to commit someone, to enact a civil commitment, to evaluate a patient for fiduciary guardianship, to assign payees, manage disability checks. All of these things can be impacted, and you can help the law enforcement with as a psychiatrist working within the health law enforcement department. Part of a larger team, the psychiatrist can also evaluate pharmaceutical or pharmacological treatments, medical conditions that also tend to affect psychiatric illness, such as delirium, thyroid, diabetes, infection, seizures, disorders, and give some insight into whether or not this person should go to the jail or whether this person really needs hospitalization. Now, some people might say, well, that's really expensive. I could hire 3 or 4 officers for the same that it would cost me for a psychiatrist. However, even though it may be more expensive than initially to hire a psychiatrist, Louisville, Kentucky, a city of similar size, did a cost-benefit analysis that only focused on the police department's reduction in cost by hiring a psychiatrist, and they found that with the crisis intervention team, the CIT, there was more than $1 million reduction in cost. So the potential benefits really are there even before you consider things like reduced liability for the police department, improved patient outcome for the police department, community satisfaction. The other things to think about is, reduced overtime, as far as instead of having to have a police officer sit in the emergency room waiting for 12 hours while the emergency room evaluates whether this person needs to be admitted or not, you have the psychiatrist in the field who can do the evaluation and then really triage more appropriately who goes where. Also, you see, according to the internal records of Albuquerque Police Mental Health, the mental health calls have increased by 50% over the past 5 years, and the Crisis Intervention Unit has been able to expand the abilities by training more and more police officers and reducing some of their costs that were starting to get larger and larger due to the increased number of mental health calls. In 2013, to give an example of just how the police departments are also much more interested in working with psychiatrists, in 2013, you only had 30 field officers attending the 40-hour course. By 2015, they had trained 230 police officers. And so right there, you can see that this 40-hour course, even though it's a whole week of time and a big commitment by the police officers, they realize just how helpful it is to start learning more about the mental health because they're dealing with it more and more on a daily basis. Since the expansion of the program in Albuquerque, they've started also keeping more detailed records, and they've looked at use of force, especially officer shootings. They've looked at decreased in jail diversion, and they've looked at other factors that affect not only patients, individuals' health and safety, but also the cost to the police department. And going down, they basically say that for all Albuquerque Police Department calls coded as a mental health related problem in 2015, less than 2% resulted in use of force. And that is a significant reduction. Moreover, less than 2% included arrests. Also, 80% ended as transport to the hospital, right? And when they got to the hospital, almost 90% of them were admitted, meaning that you really changed it from that everyone gets sent to the hospital to be triaged by the ED, to let's triage them in the field, and 9 out of 10 are going to be admitted because you've got a psychiatrist out there who realizes, yes, this person's actually going to meet admission criteria. And so that also reduced the burden to the ED in Albuquerque quite a bit. So now that we see the benefits as far as, what are the potential benefits for this program, let's talk about what are the elements of a CIT program. Basically, they were born when law enforcement communities and the mental health professionals built a partnership. And there are 3 core elements that they are built around. And that's one that is inclusive collaboration, training, and coordinated responses. Okay, so, and then the article goes on to talk about the 3 core elements. And it basically says that inclusive collaboration is where you have a program coordinator who builds partnerships through outreach, promotes the CIT program, collects and shares data, and is involved in all aspects of the program. You have an individual who's the go-to person and who can help coordinate with the police. How do we get training for the police? How do we get the psychiatrist in there, et cetera, et cetera. And in a sense, basically promote that collaboration so that the police start realizing, yes, there's some real benefit to having a psychiatrist involved, and the psychiatrist says, gosh, I really can make a difference by getting involved early in the process and not waiting for the police to bring them in. So the next part is the training. CIT programs provide, foundation and advanced knowledge in mental health. They talk and train police officers how to de-escalate the situation, right? Something that we don't necessarily think about, but that actually is something that we got trained in during our residency. Think of those times in the ED where you had someone who was extremely upset and you were able to use your calm voice to kind of bring it down, as opposed to being threatened and then becoming threatening. And they also talk about various techniques and abilities to show the police that you don't necessarily have to tase the person and bring them in order to offer them resources or in order to help them find alternatives to the reason that they're upset or the reason that they were called. One of the, or the training programs tend to be, in Albuquerque at least, tend to have 3 topics that they really focus on: safety, destigmatization, and access to resources. Because, if you can feel safe when you're dealing with someone with mental illness, you're less likely to try and engage hostility, in a hostile fashion. If you can take away the stigma, you're less likely to make assumptions that are incorrect. And if you have access to resources, you're less likely to feel unempowered or feel like your only option is to take them to jail or to the hospital. And in fact, being able to do that, being able to have this access to resources, which a psychiatrist and a social worker tend to do, really empowers the police officers to make different choices. And that's one of the reasons why they really reduced the amount of hospitalizations. They've reduced the amount of people going to the hospital. They've reduced the amount of people who have been engaged with force. And then finally, the coordinated response. Coordinated response is an active part of the CIT where you do real-time response and have clinical guidance to help the police officers when they're truly in need. So it's not something that the police officers are feeling out of their depth and don't know what to do, but they have someone that they can contact and draw on and talk through situations with. Now, if people are interested in forming or at least exploring some of these community-based intervention treatment or teams programs, there are a really good guideline out there. I mean, it's a best practice guideline. I've actually seen and reviewed it because it's something that we talk about in Apple usually annually, and have speakers about it. And there's this guideline, and it's reference 23 and 24, but these are really good practice guidelines. It was developed by a Canadian group and chief of police, and it has been spread really not by psychiatrists per se, but really by the chief of police trying to reduce the number of lethal force or even force incidents that the officers are having, to try and get the police more understanding about mental health and improve their stats, since that's become more and more an issue over the last 5 to 10 years. They also have a very structured 40-hour class for the field officers, and it's something that you wouldn't necessarily have to teach. That's actually got a guideline to tell you, who needs to come in, how is it done. There's grants to get it funded as well. And so if you're interested in getting a CIT program in your state or even in your town or district, you can do it, and there's a lot of support for it. So in conclusion, basically, psychiatrists working with law enforcement has shown that it can have a tremendous impact in terms of value serving the community. It can help with consults. It can help with decreasing the waste of hospital resources. It can increase the access to care. It can also improve the use of force or by decreasing the number of incidents, and improve the mental health of the community because they're able to get the people who need mental health treatment where they need to go. Now, having a full-time psychiatrist in a law enforcement agency may be daunting or even impossible for certain jurisdictions, especially small ones, but there are other opportunities. You don't necessarily have to do it full-time. You can do it part-time and still be very helpful to law enforcement and mental health. Because right now, I mean, we talk about the idea of mid-level providers coming in and taking our jobs or taking, our stuff. Well, right now in law enforcement, they hardly have any psychiatrists. This social workers, and nurses who are basically running all this. And so this is an opportunity to show leadership, get involved in your community, and start showing just how much a psychiatrist can offer. The collaborations may be initiated by simply contacting your law enforcement officers in a non-urgent context to start some dialogue. So, bottom line, by focusing some of our professional energy on cross-collaboration with law enforcement, we can increase understanding, reduce liability, and improve patients' lives and stability in the community. And we can also reduce the use of lethal force against persons with mental illness. In the table, right, actually table S4, it talks about percentage of officer shootings that involve people living with mental illness. And it's between 25 and 60%. That's what the studies say. So the lowest end is a quarter of the people that get shot have mental illness, and the upper end is more than a half of everyone who gets shot has a mental illness. And so if we can just simply reduce that, that would be a significant improvement in our patients' lives. With that, I'm going to conclude, and if y'all have any questions, happy to answer.
Well, thank you for that great summary. This is actually a very interesting article to me because I work in a crisis center in Milwaukee on the weekends for the county, and we do work with law enforcement, and I think the county is constantly working on the relationship that we have with the police and vice versa. But this was really interesting to hear, really helpful. And you're right, they do actually have a team now that can go out with the police on certain calls, but it is, I believe, just a social worker and a nurse. I don't think a psychiatrist ever goes out with them. So really gave me something to think about. And I think I'm going to actually forward this article to our director. He's probably come across it already, but just in case. But yeah, thank you. Yeah, I don't see any questions right now. If people have questions, you're always welcome to put them in the comments later, like in the next couple hours, and we'll try and check back within the next day or so. Somebody did ask if you have to watch the articles, or you have to watch the Journal Club live to get the CME. You do not. You can watch it anytime. Once you sign up for the CME through the American Physician Institute, you have 12 months to complete all the videos. So you can kind of do it at your own pace. I know the MOC is due at the end of the year if this is the year it's due for you. So you have a lot of time. So yeah, thanks guys. And we'll see you guys on Wednesday. All right, thanks Paul. All right, have a good night. All right, bye everyone. Bye.